Welcome, everyone. We'll get started in just a minute. A good number of people are still coming in.
Okay, so welcome everybody to this third webinar of 2024. We still have one more to go later in the year in December, but we are really excited to have you with us today on this inter-CIFAR collaboration of HIV and Women Research webinar. Today we have the pleasure of having two amazing speakers, and we're looking forward to hear their talks.
Great. Thanks, Maria. And I have the pleasure of introducing Dr. Zanny, who's an associate professor of medicine at Harvard Medical School, and she serves also as the associate chief and director of women's health research in the metabolism unit at Massachusetts General Hospital. She received her undergraduate degree from Harvard College and then went on to receive her medical degree from Harvard Medical School. And her research portfolio is both clinical and translational in nature, and it is characterizing the sex-specific mechanisms underlying increased risks of myocardial infarction and congestive heart failure among people living with HIV. Along the way, she has successfully secured and conducted multiple R01 studies as the principal investigator and is the recipient of an NIH K24 mentoring grant, where she is capacitating early stage researchers in this area. And her original research has been published in high impact journals across multiple disciplines, including infectious diseases, cardiology, endocrinology, and women's health. She is the vice chair of the randomized clinical trial, Prevent Vascular Events in HIV, or the REPRIEVE study, and the co-principal investigator of two REPRIEVE ancillary studies, including the REPRIEVE Women's Objective Study. And today we're really fortunate to be able to hear from her on atherosclerotic cardiovascular disease risks and mechanisms among women with HIV. And so I turn it over to you, Markella.
Thank you so much, Dr. Powis, for that very kind introduction. It's an honor for me to join and speak with you today about atherosclerotic cardiovascular disease among women with HIV. This presentation explores the influence of sex assigned at birth on atherosclerotic cardiovascular disease, or ASCVD, risks and mechanisms among people with HIV. The terms female and women are used in reference to sex assigned at birth. The influences of gender identification and gender-affirming therapies on ASCVD risks and mechanisms among people with HIV are also important and are addressed in comprehensive review articles. Through today's discussion, we'll explore ASCVD risks, mechanisms, and preventive care considerations relevant to women with HIV. We'll recap some REPRIEVE data recently presented at CROI, while also delving a bit deeper into ASCVD risk mechanisms, including consideration of the influence of reproductive aging. Let's begin with ASCVD risks and preventive care considerations. As highlighted in a systemic review and meta-analysis by Dr. Anup Shah on the global burden of atherosclerotic cardiovascular disease in people living with HIV, there's an approximately twofold increased risk of ASCVD among individuals with versus without HIV. In a US-based observational study by Dr. Virginia Triant, sex-stratified analyses revealed that myocardial infarction, or MI, incidence was comparable among women with HIV and men with HIV, as you can see here in the solid bars, while MI incidence was significantly lower among women without HIV versus men without HIV, as reflected in the striped bars. By extension, the relative risk of MI among women with HIV versus women without HIV was almost double than that among men with versus without HIV. and a follow-up examination demonstrated analogous trends with respect to stroke incidence. Now we have data including sex-stratified data from a global CVD prevention trial among people with HIV, REPRIEVE. As this group knows, REPRIEVE enrolled 7,669 ART-treated people with HIV age 40 to 75 with low to moderate traditional ASCVD risk, randomized these participants to pitavastatin 4 milligrams daily versus matching placebo, and followed participants for, on average, 5 years for the development of major adverse cardiovascular events, or MACE, including MI and stroke. The REPRIEVE study rationale was that people with HIV, even without overt dyslipidemia, might benefit from anti-inflammatory and/or plaque stabilizing effects of statin therapy. This past year, trial unblinding revealed that statin therapy reduced MACE among people with HIV by 36%. Of note, sex-stratified analyses revealed that the effect size of statin therapy to reduce MACE was consistent among women and men in REPRIEVE. REPRIEVE findings have prompted updates to statin prescribing guidelines in the US as well as in Europe. US American College of Cardiology and American Heart Association guidelines anteceding REPRIEVE recommended statin therapy for individuals with a history of ASCVD, a history of a very high LDL cholesterol level, or a history of diabetes, as reflected here. For all others, there was a recommendation to calculate the pooled cohorts equation, or PCE, 10-year ASCVD risk score. Statin therapy was then definitively recommended for those with a score greater than or equal to 20%, and clinician-patient discussion was recommended for those with lower scores. In February 2024, the U.S. Department of Health and Human Services issued an update to CVD prevention guidelines for people with HIV age 40 to 75 based on REPRIEVE findings. And these guidelines were as follows. For the subset of individuals with a PCE 10-year ASCVD risk score between 5 and 20%, there was a class A1 recommendation for initiating at least moderate intensity statin therapy. For those, however, with a score less than 5%, there was a class C1 recommendation for the same. Among REPRIEVE participants, baseline characteristics differed significantly by sex. And as you can see here, the median PCE 10-year ASCVD risk score for women enrolled in REPRIEVE was 1.9%, while that of men enrolled in REPRIEVE was 5.4%. Interested in assessing participants' ASCVD risk by sex, we examined MACE rates per 1,000 person years among women and men in the placebo arm of REPRIEVE, grouped by PCE 10-year ASCVD risk score, and 2 key points emerged. First, both among the women and men, MACE rates increased markedly across increasing PCE 10-year ASCVD risk score subgroups, as might be expected. And second, although confidence intervals were wide and overlapping for REPRIEVE participants in the placebo arm with a 10-year ASCVD risk score greater than or equal to 2.5%, estimated MACE rates per 1,000 person years tended to be higher among women versus men, which is an important point we're going to come back to. To better understand and build on this second finding, we next examined the performance of the PCE 10-year ASCVD risk score among REPRIEVE participants. We noted that when applied to the global REPRIEVE cohort, the score was reasonably well calibrated overall. However, there were apparent differences in score performance by sex and by region of residence. Further examination revealed that the PCE 10-year ASCVD risk score significantly underestimated risk, specifically among women with HIV living in high-income countries. And you'll note highlighted in yellow the observed to expected event ratio of 2.56 in this group. So to summarize what we've talked about so far about ASCVD risks and preventive care considerations, we know that the effect size of statin therapy to prevent MACE is comparable in men and women with HIV in a global cohort. And we know that the PCE 10-year ASCVD risk score underestimates risk among women with HIV living in high-income countries. These findings have potential clinical applications. First, enrolling large numbers of women with HIV in clinical trials and conducting sex-stratified analyses represent critical steps in understanding sex-specific ASCVD risks, as well as efficacy of prevention strategies. And what I mean by that is that if we had not enrolled a large number of women in REPRIEVE and then performed these sex-stratified analyses, we would have just examined the overall calibration of the PCE 10-year ASCVD risk score and concluded that the calibration was good. However, with enough events occurring in high-income countries and with enough women enrolled, we were able to perform these sex-stratified analyses and see that indeed the score underperformed specifically in women. So that's very important. Second, shifting how we think and counsel about ASCVD risk among women with HIV will enable us to partner in addressing modifiable ASCVD risk factors, giving due consideration to statin therapy, and encouraging discussion and workup of any symptoms of heart disease. So if we drill down on this point, when we underestimate risk, for example, among women in high-income countries, we might be less likely to try to recommend strategies to address modifiable risk factors, or we might softly recommend statin therapy with a Class C recommendation when perhaps a Class A recommendation might be in order, or we may not take seriously an atypical symptom of heart disease that a woman with HIV presents with. And so when we really have to focus on shifting our mind frame around risk so that we can do the best we can for preventing heart disease in our patients who are women with HIV. Okay, we're going to move on now to considering ASCVD risk mechanisms and preventive care considerations, beginning with a thematic assessment of upstream risk factors. In general, among people with HIV, ASCVD risk is influenced by genetic backdrop, social, behavioral, and environmental factors, traditional metabolic factors, and immune factors, with variable effects of different antiretroviral therapeutics. A broad approach to assessing factors affecting risk of MACE among people with HIV and REPRIEVE has yielded some interesting findings. We built models by category to understand which factors were potentially relevant for inclusion in a complete model. And from this final model, the following emerged as potentially salient risk factors: age, region of residence, race within high-income countries, family history of premature cardiovascular disease, cigarette smoking, hypertension, low HDL, detectable HIV-1 RNA, and entry ART regimen. So as you look at this list, you'll note that several of these factors represent modifiable risk factors. So there's room for us to move in addressing these risk factors, even perhaps as we prescribe statin therapy. That really has to be a combination approach. Meanwhile, you'll also note that female sex does not appear to be protective against MACE in this global cohort of people with HIV. And this finding runs counter to conventional wisdom that's been gleaned from general population studies through the years. This finding also helps explain why the PCE 10-year ASCVD risk score underestimates risk in women with HIV, particularly those women in high-income countries. And that is because the calculator factors in a protective effect of sex. So when we're not seeing a protective effect of sex, this is yielding an underestimation of risk by the calculator. As soon as we finish running immune biomarkers in the full REPRIEVE cohort, we'll look forward to relating these biomarkers to events overall and as appropriate in groups stratified by sex. Beyond a broad approach to assessing factors affecting the risk of MACE among people with HIV, we also need to appreciate that there are sex-specific considerations pertaining to all categories of risk factors. For example, women as compared to men may have different patterns of cigarette, alcohol, or drug exposures. They may have a different diathesis to ectopic fat deposition. And especially, women are known to have different immune responses to HIV infection, with women as compared to men tending to mount a more robust innate immune response. Additionally, we need to carefully consider menopause as a sex-specific ASCVD risk factor for women. As you can see in the graphs, for men, testosterone levels decline gradually through the full lifespan. And by contrast, for women, estradiol levels really plummet precipitously in the years leading up to menopause. For women, reproductive aging associated with menopause augments ASCVD risk above and beyond the contributions of chronologic aging. Let's have a look at these data from the Framingham Heart Study in the 1970s. So you'll see here that with every 5-year bracket of chronologic age at midlife on the x-axis, the incidence of cardiovascular disease on the y-axis is significantly higher in postmenopausal women, represented in purple bars, versus premenopausal women, represented in pink bars. Why is this the case? Evidence from general population studies has suggested that for women, menopause may be associated with increased metabolic dysregulation, as well as increased levels of select inflammatory markers. Let's drill down a little bit further. What exactly is menopause, and why is the timing of menopause challenging to identify? According to the WHO, menopause is the permanent end of menstruation resulting from the loss of ovarian follicular activity. Menopause occurs with the final menstrual period, FMP, but can only be recognized after 12 months without menses in the absence of an alternate cause of amenorrhea. So this definition yields at least 2 challenges: retrospective recognition and the need to rule out alternate causes. Reproductive aging stages through menopause are defined in turn through the STRAW plus 10 criteria. There's a reproductive phase characterized by monthly menses. Then there's early and late perimenopause phases characterized by varying degrees of menstrual irregularity. And of note, these 2 perimenopausal phases together can take on average 7 years to transpire. And then there's postmenopause. And again, as you can see here, the principal criteria for stages are based on the degree of menstrual irregularity. Select patterns of laboratory testing values represent only supporting criteria. Unfortunately, there's a long list of non-repro aging scenarios which can prompt menstrual irregularity, possibly prolonged menstrual irregularity. In clinical research and even in clinical practice, we don't always ask about these. A study from the WISE team showed that among US women with HIV who had greater than 12 months of amenorrhea, nearly 40% had reversible causes not brought about by permanent loss of ovarian follicular activity. The authors concluded prolonged amenorrhea in women with HIV should be evaluated and not presumed to be the result of menopause. What about the hormonal biomarkers that STRAW plus 10 acknowledges as supporting criteria for staging reproductive aging? As you can see here in the graph of the menstrual cycle and associated changes, including changes in hormonal markers, variation in levels of estradiol, luteinizing hormone, and follicle-stimulating hormone through the menstrual cycle really complicates the interpretation of data on these biomarkers, even among women with regular menses, let alone among women who have irregular menses. More recently, there's been interest in incorporating levels of anti-Müllerian hormone into reproductive aging schema. Anti-Müllerian hormone is produced by ovarian granulosa cells. Levels drop to undetectable several years prior to menopause and predict age at menopause. And thus, this hormone can serve as a molecular biomarker for ovarian reserves, with low levels reflecting reduced ovarian reserve or progressive reproductive aging. Levels tend to be consistent throughout the menstrual cycle, which is very appealing in using this marker for study. Doctors Rebecca Abelman and Phyllis Tien of the WISE have applied serial measurements of anti-Müllerian hormone to characterize women with HIV into one of 4 reproductive aging subgroups, and these subgroups are nicely aligned with the STRAW plus 10 subgroups, as you can see here. Meanwhile, Dr. Sarah Luby and I, both within Reprieve and also in US-based physiology studies, have combined menstrual history data with single point in time AMH measurements to categorize women with HIV into one of 3 reproductive aging subgroups: premenopausal women with menses within the year and detectable anti-Müllerian hormone, perimenopausal women with menses within the year and undetectable anti-Müllerian hormone levels, and postmenopausal women with no menses within the year and with undetectable anti-Müllerian hormone levels. Now, staging reproductive aging is absolutely critical to understanding when and how menopause influences heart disease risk in women with HIV. With respect to men, most studies, including important studies by Drs. Abelman and Tien, suggest that among women, pathology relevant to ASCVD risk really accelerates in perimenopause. And so crude systems that define simply pre and post menopause may cause us to miss the optimal window for cardiovascular preventive care interventions. With respect to how, Dr. Luby and I have shown, for example, that among women with HIV, reproductive aging is associated with increased levels of select immune and inflammatory markers, increased waist circumference, and an increased prevalence of coronary atherosclerotic plaque, even after controlling for chronologic age. Presently, we're studying the effects of women's reproductive aging on ASCVD risk and risk reduction in Reprieve. Ultimately, the goal of menopause-related ASCVD risk mechanisms research is to inform strategies for intervening at the right time on the right processes to help women preserve cardiovascular health through the lifespan. Finally, before we close, let's consider what research on subclinical vascular pathology among women with HIV tells us about ASCVD risk mechanisms and preventive care considerations in this population. As a refresher, MI is acute myocardial injury with clinical evidence of myocardial ischemia. Type 1 MI is caused by atherothrombosis in the coronary artery supplying the infarcted myocardium. Type 2 MI is caused by myocardial oxygen supply-demand mismatch without atherothrombosis. And importantly, with type 2 MI, there are a variety of options of what may be going on in the vasculature. There could be absolutely no underlying cardiovascular pathology and just a catastrophic demand event, for example, a hypertensive emergency. Or there could be stable subclinical atherosclerotic plaque in the large epicardial coronary arteries, and that plaque could potentially limit blood flow through the large arteries in setting of high demand. And/or there could be coronary microvascular dysfunction, so inability of small blood vessels to dilate sufficiently in high demand states. Several years ago, Dr. Heidi Crane published data from CNIX revealing that among US women with HIV who experience an MI, greater than 50% experience a type 2 MI. A US-based physiology study by Kathleen Fitch provided a potential explanation for increased type 1 MI risk among US women with HIV. In this study, matched groups of women with and without HIV underwent immune phenotyping and coronary CT angiography. Levels of several immune markers were higher in women with HIV. Meanwhile, the prevalence of subclinical coronary artery plaque was comparable between groups, but there was a shift towards non-calcified plaque among the women with HIV. So taken together, these findings supported a hypothesis that among women with HIV, systemic immune activation may promote pathologic remodeling of epicardial artery plaque, the kind of remodeling that may predispose that plaque to rupture and cause a type 1 MI. Our research team, including Sarah Chu and Dr. Mabel Toribio, conducted a follow-up study called INFORM, exploring a potential explanation for increased type 2 MI risk among US women with HIV. We hypothesized that among women with HIV, increased systemic inflammation might predispose not only to vulnerable epicardial artery plaque, but also potentially to coronary microvascular dysfunction. Through INFORM, we enrolled matched groups of women with and without HIV, and these women underwent CT angiography plus 2 additional assessments: fractional flow reserve for assessment of blood flow through the large epicardial arteries, as well as cardiac PET scanning for assessment of coronary flow reserve, which characterizes blood flow through the large and the small coronary arteries in response to demand. Our findings confirmed previous findings that US women with HIV have increased inflammation in the absence of excess coronary plaque prevalence or burden. Also, however, we built on those findings by showing that among women, HIV status is associated with impaired coronary flow reserve. And among women with HIV with impaired coronary flow reserve, only a minority had flow-limiting epicardial artery plaque. So taken together, these findings signal that some women with HIV may have isolated coronary microvascular dysfunction. To summarize this second half of the talk, female sex and menopause influence ASCVD risk mechanisms. Female sex does not appear to be protective against ASCVD among people with HIV globally. And among women with HIV, MI risk may be mediated through vulnerable coronary atherosclerotic plaque and or through small vessel dysfunction. Implications are again, highlight the point that we not only need to enroll women in studies and conduct sex stratified analyses, but if we're going to understand, for example, the influence of menopause, we also have to collect data relevant to staging reproductive aging. And secondly, shifting away from a unilateral focus on coronary plaque to a broader consideration of vascular dysfunction may help us in assessing risk and providing tailored therapy for women with HIV. And finally, in terms of future directions, it will be important to elucidate region-specific ASCVD risks, mechanisms, and preventive care approaches for women with HIV living in low and middle income countries. I'd like to thank very much these groups, and I know we're running short on time, so I'll turn it over.
Thanks so much, Dr. Zani. That was such a fantastic presentation, both in terms of the risk factors and looking at those mechanisms too. I don't see any questions in the chat right now, and maybe what would work best, since we've got some limited time and we want to complete by the top of the hour, I'm going to turn it over to my counterpart, Maria, at this point, and please put your questions for Dr. Zani in the chat. And if we have time, we'll get to them at the end of the talk as well. Thanks.
Thank you so much, Kate, and thank you, Markela, for this amazing talk. It is my pleasure to introduce Dr. Joel Palevsky as a second speaker for today's webinar. Dr. Palevsky is a professor of medicine and infectious diseases at the University of California in San Francisco. He trained in medicine and internal medicine at McGill University in Montreal, in Canada, and in infectious diseases at Stanford University. He's an internationally recognized expert on the molecular biology, treatment, pathogenesis, and natural history of anogenital human papillomavirus infections, particularly in the setting of HIV infection. He is the founder and director of the world's first clinic devoted to prevention of anal cancer, the Anal Neoplasia Clinic Research and Education Center at UCSF. He's the vice chair of the National Cancer Institute-supported AIDS Malignancy Consortium and the chair of the Anal Cancer HSIL Outcomes Research, or the ANCHOR study, as we all know. the study by that name, which is a national multi-site NIH study that showed that treatment of anal cancer precursors lesions prevent the development of anal cancer. And it is really an amazing finding that we all have followed over the past few years. He's founder and past president of the International Anal Neoplasia Society and past president of the International Papillomavirus Society. It is a pleasure to have Dr. Palevsky with us today to talk about anal cancer prevention in women with HIV. Welcome, Dr. Palevsky.
Thank you so much, Maria. I'm going to share my screen. And it's a real pleasure to join you today for this inter-CFAR collaboration. I am very happy to have the opportunity to talk specifically about anal cancer prevention in women with HIV. The objectives of my presentation are to understand the current epidemiology of anal cancer in women, to be aware of the results of the anchor study that Maria referred to, and to be aware of new screening and treatment guidelines for anal cancer prevention. So when we think about anal cancer, largely in part because of the focus on research in people with HIV, we tend to conflate it to some degree, the incidence of anal cancer with being either a man who has sex with men, MSM, or living with HIV infection. But in reality, most of the cases do not come from people with HIV. And in the general population, anal cancer is actually more common in women than it is in men. You can see about twice the incidence in the US of anal cancer in women compared to that of men. Of course, when you're talking about HPV-related cancer, cervical cancer is always the most important in terms of overall numbers of cases, but anal cancer is starting to increase. That's really one of the key take-home points that I want to make in this presentation. So when we talk about anal cancer, we always refer to the cervix. That's our model, and that's for a bunch of very good reasons. The first is that cervical and anal cancer are very similar diseases in terms of their association with HPV, particularly HPV-16, and their pathogenesis from initial infection of the mucosal epithelium to development of a cancer precursor, which we call high-grade squamous intraepithelial lesions, or HSIL, and the fact that this HSIL lesion has been shown to be the proximate precursor to both cervical and anal cancer. We know, for example, from many, many years of trying to prevent cervical cancer, that when we look for cervical HSIL using the cervical pap smear screening system followed by colposcopy and remove any biopsied HSIL, that very substantially reduces the risk of cervical cancer. And what we've been interested in is whether a similar approach could be used to prevent anal cancer. Why is this important? As I've alluded to, anal cancer is one of the most common cancers associated with HPV in women after cervical cancer. In addition, in people with HIV, it is the fourth most common non-AIDS related malignancy. And as you can see in the general population here, it's increasing not only by birth cohort, but more substantially in women who are older, as shown in panel B. Panel A shows an increase in men also, but the rate of rise is highest in the women. There is an interesting difference between the age-related incidence of cervical and anal cancer, which has some implications for screening. If you look at the age-related incidence for cervical cancer on the left, you see that the peak is in the early 50s, and thereafter it starts to decline. And this is one of the reasons why we tell women that many women, that they don't need to continue to get screened with cervical paps after the age of 65. But if you look on the right at the incidence of anal cancer in both males and females, you'll notice, for example, again, that the incidence is higher in the females in blue, but that the incidence continues to rise. In women, that peak is in the mid-70s, and then it comes down a little bit. In men, it starts to peak in the 60s and never really comes down. So what we see here then is that the peak of anal cancer is occurring, by and large, at a time when we've already told women that they don't need to come back anymore for their cervical pap smear screening. So if you combine the reduction in cervical cancer due to a pretty effective, not universally effective, but pretty effective cervical cancer screening program in the US with the absence of an anal cancer screening program, what we're now seeing, as shown in columns C and D, is that the incidence of anal cancer in red now exceeds that of cervical cancer in orange in white women 65 to 74 and over the age of 75. Now, I've been talking up to this point about the general population, and the incidence by and large is still relatively low compared to some other cancers, but that is not the case in certain well-known high-risk groups. And these high-risk groups are summarized in this very nice meta-analysis, which stratifies the anal cancer incidence per 100,000 person years according to group and age. So the first three groups here are all people living with HIV. They include men who have sex with men, males who are not MSM, and women. And you can see that in each of these categories, the incidence of anal cancer, as shown by an ever redder color on the risk scale, increases as a function of age. So amongst MSM over the age of 60 years who are living with HIV, the incidence of anal cancer is well over 100 per 100,000. And that is really high. In fact, it's higher than any of the incidence of cervical cancer anywhere in the world, even in some of the highest risk countries. We see a similar pattern in non-MSM males living with HIV, and in women, we also see substantially increased risk also in older groups. There are, however, two other groups to be aware of, and there's obviously some overlap. So one is that if a woman has a history of HPV-related disease in the cervix or the vulva, particularly the vulva, that risk is increased. And you can see both for vulvar cancer and precancer that that risk is quite high. The risk is lower for cervical cancer, but still we see an age-related increase. And then we have other immunosuppressed people not living with HIV. One of the most common of these is people who are immunosuppressed to prevent solid organ transplant rejection, particularly renal. And here you can see that the increase, which is, again, quite substantial, is not age-related per se, but rather a function of years post-transplant. In other words, duration of immune suppression. So when we see this, it makes me wonder at least whether some of the age-related increase that we see in the groups with HIV are a combination of biological aging, since we know that people with HIV do age a little faster than people not living with HIV, and perhaps the duration of immune suppression, since older age does correlate to some degree with having a history of HIV infection for a longer period. So maybe a combination of both factors. Nevertheless, when you look at these incidences compared to the general population, it's clear that these are the groups in whom we need to focus first if we're going to consider implementing an anal cancer prevention program similar to prevention of cervical cancer. Now, when we talk about prevention of HPV-related cancers, we have primary prevention and secondary prevention, where primary prevention is acquisition of the causative agent, HPV. That is clearly through HPV vaccination. And we showed a while ago that HPV vaccination works to prevent anal HPV infection and its consequences, anal HSIL, just as well as it does in the cervix. Based on those findings, actually, gender-neutral vaccination, boys and girls, was approved, and prevention of anal cancer was added to the list of indications for vaccination for women, even though the study was never done in women. The problem with primary prevention is that it's really most effective in people who are younger, ideally around the time of initiating sexual activity, since the vaccine really only works to prevent initial acquisition of HPV. So the issue is, what do we do for people who either don't have access to the vaccine or who are already too old to receive the vaccine? And that's where secondary prevention comes in. So secondary prevention, as I showed in that earlier slide, involves looking for these high-grade lesions and removing them prior to this event, which is progression to invasive cancer. Again, we know it works in the cervix. Big question is, can it work in the anus? We do not yet have routine anal cancer prevention programs until recently. And the main reason is because we never had the evidence that actually looking for and reducing the risk of anal cancer was possible by treating anal HSIL. So we needed the evidence before anybody was going to recommend implementation of such a program. And that's where the ANCHOR study came in. ANCHOR stands for Anal, AN, Cancer HSIL Outcomes Research Study, I think one of the better acronyms in my career. And this was a study that was performed by a large group of people of the AIDS Malignancy Consortium and funded by NCI. And we published the results of this study a couple of years ago now. And basically it showed, as you already heard, Maria stole my thunder a teeny bit, that the treatment of anal HSIL lesions did prevent quite a few anal cancers. So since the highest risk group, as I showed you in that meta-analysis, were people with HIV, this study was focused on people with HIV. And because we know that anal cancer occurs later in life, we focused on people living with HIV 35 and older. And essentially, we screened everybody for anal HSIL, which was the essential inclusion criterion to look for HSIL using high-resolution anoscopy with biopsy. And if we found HSIL, they were randomized if they met the other study criteria to either active monitoring, which meant following them very carefully without treatment, versus treatment, and then counted up the number of cases of cancer over a period of time. I want to point out one important thing before we get to the results, and that is we ended up screening 10,723 people around the United States and Puerto Rico to find the more than 4,500 who were eventually randomized. But the amazing thing and scary thing, in my opinion, was that amongst these 10,723, 53% of the men with HIV had biopsy-proven anal HSIL, 47% of the women, and 67% of transgender individuals, mostly male to female. This is truly stunning because if you, again, compare this to the general population, in a healthy group of women, for example, you would find fewer than 1% having a cervical high-grade lesion if you were to study them at random. So here, more than half of the men and nearly half of the women. We used to think that the prevalence of anal HSIL was quite a bit lower in women with HIV than men. In prior studies, that was not the case in ANCHOR. In addition, we at screening found some prevalent cancers as we were expecting. And overall, we found 23 individuals for a prevalence of 214 per 100,000, quite a bit higher even than in that meta-analysis that I showed you before of MSM living with HIV. So the key finding was that in people who were randomized, there was a 57% statistically significant reduction in anal cancer in people who were treated for their anal HSIL compared to those who were monitored. The progression rate was remarkably high in that monitoring arm. It was over 400 per 100,000 person years. And it was unfortunately still higher than I would have liked in the treatment arm, but there was a statistically significant delta. So what that says is that if you have a person with HIV with high-grade disease, there's a too high rate of progression in the absence of any action, but that our treatments, which are effective, still have room for improvement. What were those treatments? Although we allowed clinicians to use any of 4 different treatments, it was at their discretion which one, and almost everybody picked office-based targeted ablation, mostly electrocautery provided through office-based hyfurcation, which is a ConMed or a Bovie. Basically, it's electrocautery in the office. And the great thing for us, the lucky thing for us, was that since so many people picked this method, we believe that the clinical benefits that we demonstrated in the ANCHOR study were primarily attributable to electrocautery. And that's why, as you'll see in a little bit, that CDC recommended this treatment approach as first-line therapy for anal HSIL. A couple of other good pieces of news. The treatment is quick. It's done in an office setting, so it's relatively inexpensive, and it was very well tolerated, and it can be done by a wide variety of medical professionals. I myself am trained in infectious disease. I'm not a surgeon. In the days before we had these treatments, we used to have to send most of our patients to surgery. That is no longer the case. Now we send only a few % of patients to surgery. So this is what the CONMED machine looks like. This is the paddle that we use to attach to this pen that provides the electricity. One other disadvantage of this method in the past was that it would generate smoke. So you'd have to have a second person in the room holding a smoke evacuator, but there have been improvements in the tubing that actually suck the smoke up at the source. And so it's no longer a problem, which is great. We are putting together a manuscript for publication now, which actually shows that using a validated quality of life instrument, that when you do treatment for patients, you do see a very short-term diminution of physical comfort, but within a short period of time, usually within a few weeks, the discomfort resolves and the person is back to baseline. So any negative effects that we see due to the bifurcation are resolved very quickly. So the main take-home points from the ANCHOR study were that treating anal HSIL can prevent anal cancer. Guidelines from the International Anal Neoplasia Society were recently published for screening for anal HSIL as standard of care in people with HIV and some other high-risk groups, which I'll come back to in a bit. And in the beginning of July, the CDC actually came out with its own recommendations as part of the treatment for people with HIV and care of opportunistic infections. And those guidelines also recommend screening for anal HSIL in people with HIV. They restricted their guidelines to people with HIV because that's where the ANCHOR data were generated from, and also included a treatment recommendation in the form of bifurcation. So those guidelines are currently published and also can be found at the CDC website and on this web link. So what I want to point out here about those guidelines is the first thing is that we recommend starting screening for MSM and transgender women at age 35 and all others, non-MSM and women over 45. And the reason for that is the ages at which we see cancers occurring in these respective groups. The first decision point is a HRA available? Because if HRA is not available, there's not a whole lot of point in screening with cytology or HPV to determine who gets HRA. If HRA is not available, we do recommend performing a digital anorectal exam to feel for hard lumps that may indicate the presence of a prevalent cancer and assess anal symptoms, bleeding, detection of a new mass, pain that was not present before. And if any of those symptoms or the digital anorectal exam that we call a DARE are positive, then we recommend standard anoscopy because that's probably fine for finding a cancer. So here we expect to find cancers, but we do not expect this to detect HSIL, which is really what you're trying to do for prevention. If HRA is available, then we recommend assessing for symptoms and then collecting the specimens for screening, cytology and HPV, and then performing the DARE. And the reason is that the swab needs to be inserted without any lubricant. You do want to perform your DARE with lubrication, so this has to be done first. So you collect your swab, then do your DARE, and then if the screening tests are positive or the DARE is positive, then you refer for high-resolution anoscopy. I'm not going to go through this slide in great detail. This is all published, but basically the guidelines give you different pathways depending on whether the cytology was positive, how severe was the cytologic result, was it HSIL itself, or was it the most common one, for example, atypical squamous cells of undetermined significance, and then how that's used in combination with the HPV test, and whether that HPV test is positive overall for a high-risk type or for the particularly bad ones, such as HPV 16 or 18, and that determines whether you get referred for immediate HRA, or if not, what the next screening interval should be. If, on the other hand, there's no HPV testing and all you've done is cytology, that is one of the acceptable pathways, and that cytology is normal, then we recommend repeating it in 1 year. And then if it's normal for 3 years in a row, you can go to every 3-year screening. As I mentioned, the International Anal Neoplasia Society guidelines also include other groups from that meta-analysis in addition to people with HIV, This does include other groups of women, for example, a history of vulvar acellular cancer, and of course, women with solid organ transplant recipient men as well. And they recommend screening because these are groups where the incidence of anal cancer is at least 10 per 100,000. There's also a lower risk, but still high risk group of people. They're called risk category B. They have rates lower than 10 per 100,000, but still a little bit too high. And these groups can also be considered for screening, but should be a lower priority than the risk category group A. So in summary, I want to say that anal cancer incidence is increasing in women, that it is preventable, that for women living with HIV, we recommend screening women 45 years and older. You may, if you have the capacity, also consider screening other high-risk women in category A. And if you have a lot of capacity, consider category B. We do recommend that for all women that you elicit symptoms that could indicate the presence of an anal cancer. A lot of people have anal bleeding, for example, and it's unfortunately too common to immediately ascribe that to hemorrhoids. So I do recommend that you have a suspicion level that allows you to more properly explore people who may have symptoms indicating something more serious. We do recommend doing a digital anorectal exam. You don't need special training for that. There are guidelines for how to do that, but we all know how to do that. I will tell you that when you explain to people why you want to do a digital anorectal exam, it is very well accepted by both men and women. And a lot of times when I hear that the patient didn't want a DARE, it really means the doctor didn't want to do a DARE or the other primary care provider didn't want to do a DARE. I can't tell you how many times I've had women, including women with HIV, tell me how happy they were that somebody's finally paying some attention down there. And then one issue that I have not touched on much is that doing HRA is challenging. It takes a long time to learn how to do it well. It's very rewarding if you choose to do it. But unfortunately, because of that time, there is currently, especially with the implementation of these guidelines, a serious shortage of people trained to do HRA, which is bad news for patients, but great news for those looking for new research opportunities and clinical opportunities. We would love it if more people got interested and learned how to do it. I'm happy to talk to any of you about how to think about going about that. There's also great information on the website for the International Anal Neoplasia Society. So with that, I'd like to conclude. Thank you very much for having me and look forward to any discussion.
Thank you so much, Dr. Palevsky, for this wonderful talk. Really, really timely. I think a lot of us are reading the guidelines, are reading the papers, but do you really summarize in a very, very nice way to all of us? I see a question in the chat. Oh, two questions, and I know we are a little bit short on time, but do you have a sense on how much these screening guidelines are being implemented in low resource settings? In US, rural, Midwest, South, my observation is the availability is extremely low. And how do we scale up?
Yeah, so that's that was the point I was coming to at the very end, and it is a real issue. The guidelines only really came out in the last few months, so we're just starting to roll them out, but we do need to scale up training programs in particular. The availability of HRA is largely concentrated in settings where there's large HIV populations, and because that's, for instance, where Anchor was done, mostly on the East and West Coast, some in the middle, not enough in the Midwest. So there's definitely a need for that. And all of those problems are magnified in even lower resource settings. We are training people in certain places in Africa and Latin America, but it's really only just getting started. I will say that, we've had decades to implement cervical cancer screening programs, and it does take time, but the sooner we can get there, the better, because we can prevent some anal cancers.
Thank you. I'm going to read one more question from Brenna Patel. I have a hard time convincing women to undergo anal PAP, indicating that they don't have anal sex. Can you suggest some data on whether anal sex has any relationship with the risk of anal cancer in women?
Yeah, great question. In fact, there are very good data, including from the Costa Rica vaccine trial, which looked at healthy young Costa Rican women. Plenty of other data on top of that that show that roughly half of the risk of getting anal HPV is attributable to anal intercourse, and the other half is primarily attributable to spread from the cervix or the vulva and the vaginal area. One very interesting study in Australia a number of years ago showed, for instance, that when women clean themselves after going to the bathroom from front to back, the risk of getting anal HPV infection was lower than if they clean themselves from back to front. And at least in the US, I think it's quite common for moms to teach their little girls to clean themselves from front to back to reduce the risk of a urinary tract infection. So some of that is just natural spread. Some of it may be through wiping. The point is that if you've never had anal intercourse, unfortunately, that doesn't mean that you're necessarily at low risk of anal HPV infection.
Thank you so much. I think that was a great point. Okay, we have a couple of more questions, but just based on time, and we're going to close here. And these are questions regarding stratified by sex and race. I would say perhaps that it's available in the papers. But I just want to thank Dr. Palevsky and Dr. Zanni for a wonderful, wonderful webinar on two very, very relevant topics. I want everybody to stay tuned for our next webinar in December. If anybody has ideas of topics, speakers, please reach out and let us know. And I see there is also information in the chat about how to join our list, how to listen to the webinars, and they are now available online. And I'm going to let Kate and see if my coach, the co-chair of the working group with me, would like to say some final words.
No, two fabulous presentations, and we appreciate everybody joining today. This was a really good turnout from everyone, and hopefully you learned something from it. I certainly did on both presentations. So thank you both for excellent presentations.
Thank you so much.